Bismillahir Rahmanir Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. My dear students, today I'm going to talk about adenoids. Now, I hope everybody knows about adenoids as far as the ENT students are concerned, but let's just talk about it a little more in detail. So, adenoids, also called nasopharyngeal tonsil. Now that means, as in adenoids are lymphoid tissue present in the nasopharynx. The nasopharynx, whereabouts in the nasopharynx? Nasopharynx, at the junction of the roof and the posterior wall of the nasopharynx, this adenoidal tissue is present, usually in children. Now, between 3 to 7 years of age, adenoids undergo a kind of hypertrophy, and that is the usual age when a patient can get real problems. Otherwise, usually the story is the adenoids involute about the age of puberty and they disappear. Well, adenoids, as I told you, usually present in the nasopharynx, and it happens that children usually get these problems because they disappear by the age of puberty. Now, if there is an extra enlargement or hypertrophy of the adenoids, it can cause two kinds of problems. Either the enlargement itself causes a lot of problem to the patients, or the adenoids or the tissue gets infected, and we call it adenoiditis, which can get spread towards the sinuses or towards the nasal cavity or towards other areas like the pharynx or the larynx and cause problems that way. Or the size itself can block the choana as well as the eustachian tube opening and can cause otitis media and other problems. Bismillahir Rahmanir Rahim. Adenoids. Well, adenoids is lymphoid tissue present at the junction of the roof and posterior wall of the nasopharynx. It is also known as nasopharyngeal tonsil. What do you know about Walde's ring? Well, under normal conditions, the adenoids undergo a physiological hypertrophy between the age of 3 to 7 years. They start to diminish in size at the age of 7 to 8 years and usually disappear around puberty. This nasopharyngeal lymphoid tissue is part of a ring of lymphoid tissue called the Walde's ring, which includes adenoids, palatine tonsils, lingual tonsils, tubal tonsils, and lateral pharyngeal bends, while the palatine tonsils are in the oropharynx, whereas lingual tonsils are at the posterior third of the tongue, and tubal tonsils are usually situated around the eustachian tube opening, and lateral pharyngeal bends, they are situated in the oropharynx and part of the laryngopharynx on the posterior pharyngeal wall, laterally and on the posterior pharyngeal wall. Well, incidence of adenoid problems. Adenoids is primarily a disease of young children. It occurs mainly between the ages of 3 and 5 years. The problem caused by adenoids is either due to its large size or due to infection called adenoiditis. Predisposing factors to adenoid problems? Well, there are some general factors and some local factors. Among the general factors, we talk about environmental pollution, allergy, bad hygiene, and poor general health, whereas local predisposing factors are recurrent upper respiratory tract infections, and chronic tonsillitis, and so on. Well, when somebody has got an adenoid problem, then a clinical picture develops. And what we have to observe in order to diagnose an adenoid problem, we have got a nasal obstruction in the child, because the problems usually occur in children. We're talking about the child having nasal obstruction. And nasal obstruction is usually apparent by the child's mouth breathing and snoring at night, and difficulty of suckling and eating, and nasal tone of the voice because the nose is obstructed. Then comes the adenoid facies. It's a kind of flat, expressionless face due to absence of the nasolabial folds. Open mouth and dry lips occur because of mouth breathing. And hitched up upper lip, projecting incisors, dry gums, pyorrhea, and dental caries also tell us about adenoid facies. Well, inactive ala nasi, receding chin, and high eyes palate are also other signs of adenoid facies. Then one can have mucopurulent anterior and posterior nasal discharge because of adenoidal hypertrophy or adenoiditis, and sleep disturbances because of nasal obstruction mainly. So sleep disturbances can also lead to snoring, sleep apnea, nocturnal enuresis due to hypercapnia. Now, sleep apnea is obstructive sleep apnea, is obstruction of respiration during sleep because of the size of the adenoids blocking the nasopharynx. And because it's natural to breathe through the nose, the child tries to breathe through the nose, but because of the enlarged adenoids, he cannot breathe through the nose, and eventually the breathing stops during sleep, and the child becomes restless and he awakens, and then the sleep is restored later on. Nocturnal enuresis is bedwetting due to hypercapnia occurring in these kind of children. Respiratory manifestations of an adenoidal hypertrophy or infection is irritant cough in that child, while recurrent pharyngitis may also occur, and recurrent laryngitis and cough and a hoarse voice or a croaky voice may also occur because of laryngitis, and chest infections leading to dry or productive cough plus some breathing problems. While feeding problems in the same children having adenoidal hypertrophy or infection are very many, and feeding problems can be in the form of loss of appetite or indigestion and vomiting due to swallowed secretions, while skeletal changes including pigeon chest, Harrison's sulci, and depressed xiphisternum. Other clinical features in a case of adenoidal hypertrophy is recurrent earaches and deafness due to obstruction of the eustachian tubes causing recurrent otitis media and middle ear effusions. One can have recurrent earaches and deafness, while decreased mental performance because of disturbed sleep due to sleep disturbances, hypoxia, defective hearing, and recurrent respiratory infections causing long periods of absences from school leads to decreased mental performance, while examination of the throat may reveal presence of a plug of mucus, egg white in color, behind the soft palate on gagging. Now, how do we diagnose a case of enlarged adenoids? Now, through the clinical picture, which we have just talked about, we look at the clinical features of the disease, and we look at the patient, we examine the nose, we examine the nasopharynx, and we look at the adenoid, if there is any adenoid facies present, and then decide about the problem. Now, what else we can do is lateral X-ray of the nasopharynx, which can show a soft tissue mass filling the nasopharynx, originating from the roof and the posterior wall, upper posterior wall of the nasopharynx. While endoscopic examination in a child is difficult to examine with a postnasal mirror. So nowadays we've got endoscopes to examine the nasopharynx through a very narrow tube, we call the nasal endoscope. So through that tube, pass through the nose, one can examine the nasal cavity as well as the postnasal space, and adenoids can be seen very well. Now this X-ray shows a soft tissue shadow at the upper posterior pharyngeal wall in the nasopharynx, adjacent to the roof of the nasopharynx, and the arrow shows the soft tissue shadow. Now, what is the treatment of adenoids? If the adenoids are enlarged or it's infected, then the proper treatment is removal of the adenoids, and the operation is called adenoidectomy. And that adenoidectomy operation is usually done under a general anesthetic. Now this picture shows, in one picture is a nasoendoscopic picture on the left, showing a mass on the roof of the nasopharynx with choana visible in the picture down below. Two choanae with inferior turbinates visible with the part of the vomer dividing the nasal cavity into two. Now, the other picture is on the right side, is showing us adenoidal tissue after being removed. Now, indications of adenoidectomy or removal of adenoids can be very many, but mainly we divide into two. Either the indications fall under the infection category or the obstruction category. Now, if it's due to adenoiditis, that the adenoids inflamed or infected, they can lead to recurrent or chronic sinusitis due to adenoiditis, while secretory otitis media due to infection traveling towards the middle ear cavity through the eustachian tube, while recurrent acute otitis media in children can also occur. So that is the problems due to infection, and one thinks about doing an adenoidectomy to relieve the condition. While obstruction problems due to adenoidal hypertrophy can lead to nasal airway obstruction or obstructive sleep apnea syndrome or chronic mouth breathing and hypernasal speech. All these problems, they indicate that there is a nasal airway obstruction along with sleep disturbances, and the only treatment in those cases can be adenoidectomy. Now, contraindications of adenoidectomy can be almost any acute infection of the body, especially acute upper respiratory tract infection. because there are chances of spread of infection during anesthesia. Then cleft palate is a contraindication to adenoidectomy because that can lead to, if one does adenoidectomy with a cleft palate patient, one can have velopharyngeal insufficiency, and that has to be avoided by doing an adenoidectomy in a cleft palate patient. Bleeding disorders, one usually tries to avoid adenoidectomy operation because bleeding diathesis and disorders lead to a lot of bleeding, and one tries to avoid such problems in routine cases. As far as the operation is concerned, adenoidectomy is usually done, as I told you, under a general anesthetic, and the position of the patient under a GA, the oral endotracheal tube is inserted through the mouth, and the patient is lying on the back in a supine position. It's called a roses position, with a sandbag under the shoulders of the patient in order to extend the neck. Now, that is the position, and the surgeon usually stands at the head end of the patient. While the patient is in that position, one tries to remove usually the adenoids with adenoid curette. That is a curette which sweeps and cuts through the adenoidal tissue and removes it. But that leads to bleeding, and nowadays other methods have been tried, like removal of adenoids by means of coagulation and by means of debrider. There's an instrument called debrider which removes the tissue of the adenoids piecemeal and leads to less bleeding. And coagulator is another type of operation in which there's less amount of bleeding and less pain, and healing is better. So that is the type of operations done, while adenoidectomy does not lead to a lot of bleeding normally, but if there is a bleeding at the time of operation, one packs in the nasal cavity, nasal pharynx for a few minutes. That usually serves to control the bleeding, and that pack is removed and the patient is sent back to the ward. Now, complications of adenoidectomy can be divided into non-iatrogenic and iatrogenic. Non-iatrogenic means it's not due to surgery that the patient is having the problem, while iatrogenic means because of surgery the result is in the form of some complication. So non-iatrogenic can be regrowth of adenoidal tissue after adenoidectomy, or hypernasality of the voice because of temporary pain, splinting, or velopharyngeal weakness. While iatrogenic, because of the operation itself, one can have bleeding due to excessive curettage or presence of aberrant vessel. So there can be dental injury or tooth fractures. There can be nasopharyngeal stenosis due to fibrosis after adenoidectomy. There can be eustachian tube injury if one goes too far laterally. Now, lingual nerve palsy caused by pressure from the tongue blade of the mouth gag can also occur, while cautery burns caused by operator error or equipment malfunction can also occur, leading to stenosis and fibrosis, while a rare complication, atlantoaxial subluxation, also called Grisel syndrome, which presents with persistent torticollis 1 to 2 weeks after surgery. Well, that's all about adenoids and adenoidectomy. Thank you very much.